All right, thank you, Annette, and thank you to the organizers for being invited to come here. It's been beautiful so far. What I want to talk about today, and the title that I was given is Molecular Mismatch. I'm going to first figure out how to use this. I have no disclosures, and I'm going to start by defining the problem. And that is that if you look, it's not just the lab that has variation in practice and variation in how things are defined, it's also physicians. And in fact, when this has been surveyed, and as you can see, well over hundreds of thousands of patients, what's been discovered is there's lots of variation. That itself is fine because there's lots of variation in patients as well. You'd expect that. What you wouldn't expect, though, is that when you statistically try to explain that variation, what has been found is that almost none of the variation can be explained by patient-related risk factors, whereas the main cause of the variation is actually center effect, which is a fancy way of saying that wherever you got your transplant done, that's how you were going to be treated, and it had really little to do with patient-related factors. So that's actually a problem. And one of the reasons I think this is a problem is that our current methods of alloimmune risk assessment are actually inadequate to allow us to risk stratify patients and refine our standard of care. And I don't know if you've thought about this, but I was thinking about it while Annette was talking, that at least in kidney transplantation, as you may know, roughly half of our patients lose their graft from death. And the other half of the patients, the number one cause of graft loss is alloimmune injury. And if you think about it, that's really a conundrum because the drugs that we use all increase the risk of death. As you may know, the common causes of death are cardiac, infection, and cancer. And all of our drugs increase that risk, whereas the other cause of graft failure, immune-mediated, is the reason that we're giving those drugs. So this is actually a perfect situation where we need what's called precision medicine. And this is medical care that's designed to optimize efficiency or therapeutic benefit for particular groups of patients by using either genetic or molecular profiling. Now, one of the things that the STAR paper did a good job of, and it's been introduced already, is identifying that there really are two types of alloimmune risk. There's immune memory, meaning you've been previously exposed, and then there's primary, sometimes called de novo alloimmunity. And if we think about what are the major correlates that we know about for these two branches, for immune memory, we know that we have sensitization history that we can ask and rule out. We have DSA screening, which is highly sensitive. And in the future, which I've grayed out at the bottom, we may have memory B and T cell assays. These are in development, but they're certainly not widespread yet. And I think in the past, I've grayed out PRA because I think this is something that people have used in the past and some centers still continue to use, although there is good literature from both Emory, from Basel, Switzerland, and from our own group that has delineated that if you actually comprehensively type across all the loci and carefully look for DSA, that third-party HLA antibodies don't actually predict outcome. But where we are in 2019 is that if we have serial sera and we, both the historical and current sera are negative, we have no sensitization history, we can be pretty confident that memory doesn't exist. And when we have memory, we have ways of avoiding it, like the highly sensitized patient registries and paired exchange. And so in actual fact, if you try to avoid this, the vast majority of transplants, we can avoid this. Nevertheless, that still leaves our primary alloimmunity. And the correlates on this side, that at least the ones that we can all agree on, are things like recipient age, HLA mismatch, immunosuppression adequacy, and I've grayed out ethnicity because I think this is actually, again, not going to help us in the future. This is a risk factor that's really confounded by HLA mismatch. It's also confounded by immunosuppression adequacy, since we know that there are differential rates of drug metabolism, and of course there's differential rates of drug access, especially in the US. And of course, we live in a global society where there's genetic admixture, and actually self-reported ethnicity is becoming less and less precise over time. And if you think about this list, it's a pretty small list. And in fact, if you consider what's available at the time of transplant, it's even smaller, because at that point, we really only know about recipient age and HLA mismatch. Now, how could we actually detect that primary alloimmunity is going on? As was mentioned, I'm an MD and a nephrologist, so this is skewed towards kidney transplant. But some of the methods that we have are de novo DSA development, and I'll talk more about that on the next slide. Of course, we have allograft dysfunction that we can look for, but as many of you know, this is a late finding which has been proven over and over again by protocol biopsy studies. And as was mentioned yesterday, the gold standard is histology. But of course, to do serial biopsies is difficult because of the invasive nature and because they're costly to do. And it has been mentioned multiple times that there are many other investigational biomarkers in the pipeline, but currently none approved by the FDA. So why could we use DSA monitoring? Well, as I mentioned, it's a highly sensitive assay. Some would argue it's even too sensitive, and we're finding antibodies that we're not sure what to do with. It's widely available, it has a quick turnaround time, it's non-invasive, it's certainly less costly than biopsies, and it's semi-quantitative. But probably most importantly is that it correlates with hard outcomes like antibody-mediated rejection and all-cause graft loss. And I use this cartoon on the bottom to just remind me to say that when we measure a new antibody in the sera, we are not just measuring a B-cell response, because we know that naive B-cells require T-cell help to become antibody-secreting plasma cells. So we are really measuring both B and T-cell alloimmunity. Now, as many of you will know from the literature, and this is just our own data here, the vast majority of de novo DSA that develop are against the class 2 antigens or against the combination of class 1 and class 2. And as it turns out, for reasons that are not well understood, these are also more pathogenic, at least in terms of quantifying their risk of both graft failure as well as antibody-mediated rejection, as you can see on the bottom. And so our research program has really focused largely on the class 2 antigens, in particular DR and DQ. So with that introduction, now I'll do what I was asked to do, which was talk a little bit about molecular mismatch and why do we need it and how could it help us. Well, I use this slide to say why we need it. And what you're seeing here on the top and bottom are antibody-free survival curves for DR on the top and DQ on the bottom. And I'm using HLA antigen mismatch to risk stratify here. As you can see in the green line, if you have zero mismatch, as we'd all expect, you're very low risk for developing an antibody. Unfortunately, there is no statistical difference between a 1 or a 2 mismatch at either DR or DQ. And this is a problem because there are 600 patients plus in this analysis. And if you can't tell the difference in a risk factor with 600 patients, this is going to be very difficult to use in individual patients that you're seeing in the clinic. And as you all know, and I'm well aware of as well, if you look at the registry studies, of course, we can show a difference with these kind of outcomes if we expanded this to 60,000 patients or 100,000 patients, which has been done. However, that's not really the world that we live in the clinic or in randomized studies either. And this slide was shown yesterday as well, but I'll just remind you that we actually know the reasons for what I showed on the last slide. So we think about the antibody antigen interface or the antibody epitope interface. We know that it's small clusters of amino acids or CDRs on the antibody that are interacting with these small clusters of amino acids on the target epitope. And so although we assume, and one of René's theories was this central small cluster was probably the epitope, the part of the epitope, or which he called the eplet, that was driving this response, the reality is that these small clusters probably just represent the smallest functional units that we can really analyze and start to compare. So to take that one step further and again try to clarify terminology, we can identify polymorphic amino acids on the surface of the molecule, and we can ask using simple software to show us the amino acids that are within a 3 angstrom radius, which is roughly the binding surface area of one of those complementary determining regions. And this differs obviously from the full epitope, which is more like 15, 16 angstroms. However, we do think that this small functional unit might be important. And you can probably imagine that if we did this for every polymorphic amino acid that exists, we could quickly generate a large list of eplets that then could be used to compare and quantify the difference between any two HLA molecules. So we've done this in almost 700 patients or donor-recipient pairs in our own clinic. And this is what the raw data looks like. Each dot here represents a donor recipient pair, and you have the eplet mismatch on the y-axis and the conventional mismatches on the x-axis. So the important note here is that there is a tremendous range of eplet mismatch within any given conventional mismatch. And this alone actually explains why we don't have a statistical difference when we have a small number of patients. For those of you who like statistics could probably also imagine that if I increase this analysis to 100,000 patients, what you'd see is eventually those confidence intervals would tighten up and you would be able to show a statistical difference. The problem is, of course, that this is where we live and work, where we see recipient A at 8 in the morning and recipient B at 8:30, and we're being asked in the clinic to actually use this information to try to risk stratify and select therapies and select immunosuppression targets. And of course, this suggests that we may have been doing this wrong for many decades, at least at the patient level. It's not to say that at the population level that we had the wrong idea, but we could be easily misled by just looking alone at the antigen level data and in fact have it backwards. If we actually use this molecular mismatch approach to do the same thing I showed you before, this is again antibody-free survival, it's the exact same group of patients. The difference here is this time I've used the eplet mismatch to define a threshold that we identified using a receiver operating characteristic curve analysis. And you can see again, zero mismatch, of course, low risk, but unlike before where we could not statistically tell the difference between the rest of the patients, you can see here that we can nicely break the rest of the patients into two groups that are high and low risk for antibody development over time. So that would be an example of a so-called prognostic biomarker, something that we can use early on to prognosticate later. As you may know, a predictive biomarker is something that actually predicts a response to therapy, and we wanted to look at this in detail, so we actually pulled down about over 50,000 tacrolimus levels from our own cohort here and analyzed them in some detail. And what we discovered, first of all, is if you looked at patients who were high risk for developing an antibody, which is both patients in the red and blue bars here, what we discovered, and which was not really a surprise, is that those who have the highest frequency of tacrolimus levels below the target were the ones who were more likely to develop the antibody. And if you have time to read this paper, you'll see that we could actually show that it was the last 6 months before they developed the antibody that were actually critical. But what was more interesting is if we looked at the patients who were defined a priori with low alloimmune risk, meaning their eplet mismatch was in the low risk category, you can see that they actually could tolerate the exact same frequency or maybe even higher frequency of tacrolimus levels that were below target, but without ever developing the immunologic event. So it wasn't actually the immunosuppression that was protecting them. It appears to be their better mismatch that was protecting them. Now, one of the things that I was asked to do in my invitation is to compare the different methods. And unfortunately, with the 20 minutes that I have, I won't be able to go in much detail, but I wanted to list and say a few comments about each one. We've primarily used HLA Matchmaker in our own clinic, and this is probably the most common one in the literature as well. But others exist. So there is electrostatic mismatch and amino acid mismatch. Both of these have been developed by Vasilis Kosmoliaptis in Cambridge in the UK, who has become a friend and a collaborator, as you'll see on the next few slides. And so electrostatic mismatch really refers to quantifying what is the physiochemical properties of the amino acid side chains on the amino acids that are mismatched. And he's developed a way of converting that into a score that then can be compared. Amino acid mismatch is exactly as the name suggests, just counting up the number of amino acids that are different. PERCH, which is actually based on the net MHC2 pan, is actually somewhat different in that here they're actually comparing donor and recipient molecules and asking the question which are more likely to present in the T cells that the recipient has. And although that seems like it would be a different question, at least the way that they've designed the program so far, the EC50, or the concentration that you'd expect 50% binding, is actually so kind of all-inclusive the way they've defined it. I would actually argue that so far they're just really looking at polymorphism in general. And the last thing at the bottom, the EMS3D, is the newest version of what Vasilis has been working on. And he's got one paper published already that's not in a transplant context, but in a different alloimmune context. And I won't be able to go through that in detail, but really what he's doing is trying to first define the three-dimensional structure of the common HLA molecules, and then compare both the amino acid differences and the electrostatic differences in a single analysis. And I encourage you to read that if you're interested. But I really will argue that all of these are based at their foundation on the genetic and/or amino acid polymorphisms. This is strengthened, this argument, by actually the time that we have directly compared both amino acid mismatch and electrostatic mismatch with the eplet mismatch at each locus. We saw that, as one would expect, they are highly, highly correlated. We use this information then to put it into various multivariate models. I don't expect you to read that, but if you look at the numbers that are in red there, those are the so-called AIC scores, or Akiki information criteria. This is a statistical way of comparing multivariate models. And as you can see, they're all pretty close to each other. In the AIC score, a lower score is better. So you could argue that of the three here, the eplet mismatch performed the best. Although I'd say that this is statistically better, it may or may not be clinically any different. Just to show you, a perch score, as I mentioned, although it should be asking a different question, because of the permissibility and the way they've designed it, it actually also correlates very strongly with the HLA matchmaker score. With the remainder of time that I have, I want to switch gears a little bit and talk about something that we've been working on and is currently in EPUB and AJT since November. I don't think it's in print yet, the last time I checked. And that is to try to increase the precision of the molecular mismatch score by bringing it to the single molecule method. So what do I mean by that? Well, if you think about what we've been doing for a number of decades, if you imagine that these are two DQ molecules, what we've really been doing is saying, okay, each of these antigens is different, so we can add them both up and get a score of 2 antigen mismatches, and then we've used that number to try to correlate with some sort of alloimmune response. When we switched to using eplet mismatch, we kind of did the same thing, but a bit in a more detailed way, where we looked at the mismatches at the eplet level in both of these molecules. We added those numbers up. We got some sort of number, in this case was 12, and then we correlated that number with the alloimmune response. The single molecule approach is to say, well, there's 2 different molecules here. Each has a risk of developing an antibody, so why don't we analyze them independently? And I usually don't even bother mentioning this to a physician audience, but I'm sure some of you are already thinking, well, isn't it possible the antibody could have a shared epitope across both of these molecules? And certainly that is the case. In those situations, I would have called both of them positive. And of course, that will lower the statistical accuracy of this type of assessment. Nevertheless, if we actually compared the AUC scores of these various methods, you can see that the traditional method that we've been using for a long time is very poor. An AUC score of 0.5, of course, is like flipping a coin, so it's not much better than that for reasons we already went through. The eplet mismatch sum is significantly better, and the single molecule method had another significant improvement in the AUC, at least for predicting DSA. Of course, the problem with this is now you have, even across the 4 different possible HLA DR beta 1 and beta 3, 4, 5 molecules. You then have the DQ alpha beta molecules. And so now we've got a different score for all of these different molecules. How do we actually bring that back to the patient level and say something about patient risk? Well, of course, the way you have to do that is define a cutoff that's high risk or low risk. And so we, again, used receiver operating characteristic curves to do that. And we came up with a single molecule cutoff of 7 for DR and 9 for DQ. So if we apply those cutoffs to the patient profile, this is what we see. And again, now here the y-axis is slightly different. It's both DR or DQ, de novo DSA development, so it really is just asking one question for each patient. Did they develop either of these antibodies, yes or no? And as you can see, as usual, the green line of the 0 mismatched patients are low risk. But now we have another group that's also low risk, and those are people who are not 0 mismatch, but they have all of their molecules. When we looked at each one individually, the molecules are all below those thresholds that we just mentioned. As it turns out, if you add these together, they make up about 25% of the cohort, about a quarter of the patients. As soon as I showed this data to some of my colleagues, they immediately asked me, well, why don't you break up the red line into high and low risk groups as well, since you have so many patients still left over there? So that's what we did. We repeated the receiver operating characteristic curve analysis. We generated a second cutoff using the DQ mismatch of 15, and as you can see, at least percentage-wise, now we have almost a third or so of the patients in each risk group. If we analyze how these risk groups work for predicting either DR or DQ de novo DSA-free survival, what you see is that each group here now is nicely and statistically significantly different from the other in terms of low, intermediate, and high-risk groups for DSA development. And we then applied this score. So the score was generated using data from DSA development, but we then took the scores and just applied them to some other questions. In this case, antibody-mediated rejection-free survival. And you can see, once again, the score was also statistically able to prognosticate for antibody-mediated rejection. And this was also true for T-cell mediated rejection in the first 12 months. And each of these, although I don't have time to go through all the multivariate models, if you choose to read this paper, you'll find that each of these has the immunologic mismatch score is both an independent predictor in each of these for multivariate models as well as for all-cause graft survival. So one of the ways I think this differs from all of the things that Anat just mentioned of all these cutting-edge technologies that are on the way is that everyone in the room can do this right now. This does not require fancy assays or different equipment than you guys have available in your lab right now. And in fact, as many of you know, as I think many in the audience will have at least dabbled with HLA Matchmaker, if you already have the 4-digit typing, the time it takes to move on and get the eplet mismatch from that is measured in minutes. 5 to 10 minutes, you can put in the typing and produce a result. It's inexpensive in that the software itself is free, and as all of you know, it's now actually incorporated directly in the most recent versions of Fusion. It's also widely available, but almost by that same definition. It's quite good as a prognostic biomarker, as I showed you, at least for DSA development. And it's available at the time of transplant. And so we've actually started incorporating this into our decision-making right at the time of transplant. And although this took some time to get everybody in the lab comfortable with producing these scores, what happened is the physicians, because they are aware of the research we're doing, they just kept asking the lab for the scores anyways. So eventually the lab gave in and said, okay, we'll give you the scores. And so the way that we've done it is that we have kind of promised as a lab to at least give the scores by the morning of the transplant if things are happening in the middle of the night, and that allows us to use these scores to select induction therapy. So I already mentioned that we're using these scores. If you think about the different ways prognostic biomarkers are to be used and predictive biomarkers are to be used, one way, of course, would be allocation. I'm not going to talk a lot about that, but I think we can all understand how allocating to lower risk mismatches would be potentially beneficial. A second one, and really the meat of this conference, is precision medicine. And in this context, we would have a score. If you think about precision medicine, really the a priori need in precision medicine is a precise risk factor. And I would argue, as I went through those risk factors that we have at the beginning, that really HLA mismatch and age are the only two precise risk factors that we have. And even HLA antigen mismatch has not been precise enough in the past. Age is a tricky one because, again, although we all understand that younger patients are higher immunologic risk, and we think that's because of a robust immune system, we don't actually know what the proper cutoff is that defines high and low risk age, and that's one of the things that we're still investigating. But if we did have a method of identifying high, low, intermediate risk people, we could then use that to personalize our immunosuppression strategies. And of course, we could also personalize our monitoring strategies because, as many of you know that have tried to implement DSA monitoring strategies in your own labs, it's time-consuming, it's expensive, it's resource-intensive. And I just showed that approximately a quarter of the patients have a 1% incidence of de novo DSA at 10 years. So these are probably not the patients that you want to use all of your resources and time to monitor. Perhaps those people only need to be monitored very infrequently, and we can spend our resources on the high-risk patients who need more monitoring. And of course, no monitoring strategy is going to be perfect. We're going to have patients who once looked low risk and then became non-adherent and moved themselves into high-risk categories. So this has to be a living assessment strategy that you're reassessing all the time. Lastly, and this is my last slide, is that industry has really been in a drought in transplantation, as was mentioned by Annette, and one of the reasons for this, and as this was identified by the FDA back in 2012, is that we do need better both prognostic enrichment strategies and predictive enrichment strategies. So in this context, a prognostic enrichment strategy is choosing patients with a greater likelihood of having a disease-related endpoint or a substantial worsening of condition, whereas a predictive is choosing patients more likely to respond to a drug due to their disease characteristics. And I think, as you can see, this could potentially fit into both of these categories, and as you may have heard already, we have actually sent in a letter of intent to use HLA molecular mismatch as a FDA-approved biomarker. That letter of intent was accepted, and so now it's in formal approval pathway with some feedback already given to us. Again, if you go onto the FDA website, you can see our letter, you can see the feedback the FDA gave us, and you can look at that in more detail. So with that, I will stop. I'll leave some time for questions, and I want to say thank you to the invitation, as well as thank you to my mentors like Peter and David and the other people we've worked with.